Since 2014, over 3 million Californians have become newly eligible for Medi-Cal with the passage of the Affordable Care Act, or Obamacare. But Medi-Cal is facing a $1 billion ticking time bomb, and Governor Brown's call for a special legislative session to address the problem ended without a fix. Now what? We'll talk to Jennifer Kent, the director of the California Department of Health Services, Felix Su, a healthcare expert with the Legislative Analyst's Office, Anthony Wright, the executive director of Health Access California, and Bill Emerson, the senior VP for the California Hospital Association. Year 2 of Obamacare. How's the patient doing?
Additional funding for the Maddy report made possible by a grant from The Wonderful Company, harvesting health and happiness around the world, and by Kaiser Permanente. Thrive. From the California Channel at the State Capitol and the Maddy Institute, it's the Maddy Report with Executive Director of the Maddy Institute, Mark Kepler.
Welcome. As the state's Medi-Cal rolls have swelled with the advent of the Affordable Care Act, what are the issues confronting Medi-Cal as it attempts to absorb millions of newly eligible Californians onto their rolls? Our guest is Jennifer Kent, who is the head of the California Department of Healthcare Services in charge of Medi-Cal. Welcome.
Thank you.
So, California has been lauded for its efficient and effective implementation of the Affordable Care Act. How much has Medi-Cal actually expanded with the implementation of the Affordable Care Act?
So since January 1st of 2014, we have grown by almost 3.5 million beneficiaries. So we're standing now at about 12.5 million Californians in Medi-Cal, which is
12.5 million. That's an amazing number.
Roughly 1/3 of the state's population.
I think
yes.
people just have to absorb that 1/3 of the state's population are on Medi-Cal.
Yes.
So pretty big expansions. Some people are worrying, though, that this is a new expense on the state budget, but it's really not a new an additional expense, really, is it?
No, so Medi-Cal is complicated. It's an entitlement program. We pay a piece of the program's responsibilities, and the federal government pays the other half. For the new expansion population, as part of the Affordable Care Act, the newly expanded members are paid for by the federal government at 100%.
So the federal government is paying all of these new additions?
For the new expansion members,
right.
Yes.
But then they phase it out a little bit over time. I think
yes.
it drops by 10% over by, I think, was it 2020?
Yes, it'll go down to a 90-10 match. So we'll put in 10 cents, and the federal government will pay 90 cents.
That sounds like a pretty good deal.
It's better than our 50-50 match for everybody else.
Right. Someone negotiated well on that. Right. Well, some have wondered with this expansion of Medi-Cal, you have this issue of reimbursement rates, and some are concerned that it's maybe going to be increasingly difficult for Medi-Cal beneficiaries to get doctors because they're swelled. The number of Medi-Cal beneficiaries have swelled. Reimbursement rates are a little low, so the doctors may not sign up, and so while you have coverage, you may not be able to get a doctor. What do you say to that?
Again, Medi-Cal has two separate programs, really. We have Medi-Cal Managed Care, for which 9.5 million members are enrolled, and then we have about 3 million individuals that are in our fee-for-service program. The individuals in fee-for-service are usually there under a limited scope, so they don't have full scope benefits, or they are temporarily there while they are choosing a health plan and enrolling with a health plan. We have 22 health plans that we contract with. We believe that the health plans are obviously the better way to deliver care. They're legally required by both our contracts and by the regulatory entity that oversees them to have adequate networks. They have to have contracted physicians, hospitals, pharmacies, and so we regularly oversee those networks. The regulator oversees those, and as part of our fiscal responsibility with them, we pay them rates that go through an actuary, and then the federal government approves our rates and has actuaries on their side. So rates are upgraded every year based on each health plan's cost and utilization. So it's really not something that we think is detrimental to the individuals that are enrolled in managed care.
Well, the idea behind managed care, you're talking about managed care systems and fee-for-service systems, and the idea behind managed care is that Medi-Cal beneficiary pays a fixed fee for a service for it to be covered.
We, the state, pay the fixed fee.
Okay, I'm sorry. I'm sorry. You, the state, do. And the idea is that since you're getting these MCOs are getting paid a fixed fee, that it's beneficial to them to either A, keep their beneficiaries healthy so they don't use the service, or B, if they do use the service, make sure it's done as efficiently as possible. Has that been your experience? Yeah,
so we regularly get financial data from the plans. There are times in which the plans can come to us and say, we've had in one particular plan in the Central Valley came and said, we had a really high incidence of cancer last year, and they were able to give us data that showed that they had a lot of individuals with cancer, a lot of very expensive drugs, and their rates were really out of sync with what we were paying them for what those individuals were costing them. We adjusted those rates. So on individual case-by-case basis, we can certainly do that. But overall, we monitor the plans pretty closely. We watch their financial health. We look at their reserves. And we're pretty confident that the rates we pay them on an annual basis cover the population, make sure that the providers are paid adequately, the hospitals, the docs, they take care of it for us.
Well, California currently imposes a tax on plans that accept Medi-Cal patients to help pay for Medi-Cal and other services. The federal government then gives $1 billion in matching to help finance Medi-Cal, and now the federal government is saying the way California taxes those Medi-Cal providers isn't right. They want you guys to change it, and if you don't, they're going to pull their $1 billion. What exactly is the problem here?
So we have had a tax on managed care plans since 2008, 2009. It has been great because we, as part of our actuarial rate setting process, tax the plans. They account for it in their rates to us. We pay them back the tax. And so it has been a really nice self-generating, no harm, no foul type of tax. The federal government recently had a study done in Pennsylvania where the Office of Inspector General came in and said, you can't do that. There's requirements around provider taxes under Medicaid law, and they said you have to come into compliance like all other provider taxes. So we have a hospital tax in the state of California. We have a nursing home tax in the state of California. They're treated differently. And the federal government said you have to treat the managed care plans the same as you treat the other taxes.
And so now we have to work out that problem.
Correct.
I want to thank you for that overview of Medi-Cal's current operational challenges. So what about Medi-Cal's future fiscal challenges? That conversation in a moment. This is the Maddy Report. So what are Medi-Cal's future fiscal challenges? Our guest is Jennifer Kent, the director of the California Department of Healthcare Services in charge of Medi-Cal. So every year we hear about health and human services that need funding, things like increasing the Medi-Cal reimbursement rates, or providing more services for the developmentally disabled, or funding in-home health support services so the elderly and disabled can stay in their homes. I guess the first question is, can we squeeze more efficiency out of the existing system to take care of those things without raising taxes?
We certainly try wherever possible, but Medi-Cal is slightly less than $100 billion a year. Our weekly check write is around $450 million, and our monthly...
When you say $100 billion, though, the state isn't paying $100 billion, just to be clear about that.
No, the state is paying about 18 to 19 billion in general fund, and the rest is either federal funds, or we use county funds. We have provider taxes. We have a variety of other...
So the state maybe can focus on that 18 billion and see what they could do to save money there.
A little bit. I mean, it all goes into one big, program, and so wherever we can squeeze efficiencies, we certainly do. We think that the way we pay health plans is one of the most efficient ways in terms of we pay them a monthly capitated amount, they manage the risk of individuals, and we have a lot of individuals in Medi-Cal that are extremely sick or disabled. I mean, that it's a low-income program that has traditionally served very sick and critically ill individuals. To the extent that we can do that better, we try, but we have people that are very, very expensive with cancer, with hemophilia, with cystic fibrosis, so we do our best.
But I think the plans have an incentive also to try to reduce costs as much as possible.
Absolutely.
So what if more money is needed? Or where do you get it? One of the things that people are talking about are perhaps raising the tobacco tax, $2 a pack or something along those lines. How much money would that raise? Would it take care of these expenses?
It would certainly help. I think the tobacco tax estimates have shown that it would raise approximately $1.5 billion. It's a steadily declining tax. Right. Obviously the idea is that people stop smoking when they have to start paying more. We obviously spending almost $100 billion in a single year. $1 billion would have to be very carefully targeted towards areas and providers of greatest need. So certain areas that are rural, perhaps where we need to encourage physicians to move and actually provide care, or specialty providers that are otherwise not in the program today, we would use that money in a very targeted and narrowed approach.
So we have this issue of the MCOs, Managed Care Organization. We were talking earlier about the federal contribution of $1 billion, and now the federal government saying, we don't like the way you tax these plans, so you need to change that or we're going to pull our $1 billion. The governor has made a proposal to address that problem. What was the governor's proposal?
We proposed a tiered tax on all managed care plans in California that was really pegged towards enrollment. So what we tried to do is tier the tax and have the tax amount most heavily on the Medi-Cal managed care plans, because again, that tax is regenerated and paid back to those plans with as minimal an impact on the commercial products, so that it still raises about $1.5 billion, or slightly less than $1.5 billion, but the net impact on the commercial insurance market is around $118 million.
What was the major stumbling block? Why didn't it get approved?
You still had some health plans that had regional market concerns. So when they have to add a little bit of a tax on their premium and they're competing with another commercial health plan, they were worried about what that did to their affordability vis-a-vis another plan in that market. And so even $118 million spread across a commercial population in certain areas, health plans were concerned.
So this flat tax, what's the argument against the flat tax then? It sounds like when people hear a flat tax, well, that seems fair. Everybody gets charged the same. Why is a tiered plan better than a flat tax?
A flat tax is great if you're a small plan. A flat tax is pretty bad if you're a large plan, because it essentially, for example, say it's a $5 per person tax. If you're a plan in the state of California that has millions and millions of members, $5 a head is far more significant of a hit than a plan with only 100,000 lives enrolled. And so we were trying to mitigate some of that impact on the larger plans in the state.
So in the tiered system, is it the smaller plans would have to pay a little more per person?
No, we tiered it. The Medi-Cal managed care plans, by and large, tend to be between 200,000 and 1 million members, and so the very, very highest levels of tier were in that spot. Mm-hmm. And then as you got to be larger and larger, the amounts dropped down significantly to 75 cents, whereas in the Medi-Cal side it was $20.
Okay. Well, thank you for that overview of Medi-Cal's future fiscal challenges. Up next, we'll try to answer the $1 billion question. What are the pros and cons of the flat tax versus the tiered tax? That conversation in a moment. This is the Maddy Report. A major sticking point in the legislature's recent special session on health care was how to tax managed care organizations, or MCOs, so that California would continue to be eligible for $1 billion in federal reimbursements. So the key issue there was, do we do it by a tiered tax, as the governor proposed, or we do it by a flat tax, as some legislators have proposed? And our guest is Felix Su, who's an expert with the Nonpartisan Legislative Analyst's Office. Welcome.
Thank you.
So before we talk about how tiered taxes and flat taxes are different, let's talk about how they're similar. How are they similar?
Well, it's a great question. And for our discussion, I'll assume that we're talking about both approaches being designed to raise the same amount of total revenue. So aside from that, the main similarities would be, one, both approaches would tax health plans on their Medi-Cal as well as their commercial enrollment. Two, both approaches would allow the state to actually reimburse the health plans for the Medi-Cal side of the tax, so they can hold the health plans harmless for the tax they owe on Medi-Cal. And by doing that, they're providing a Medicaid payment, which draws down federal funds. Three, the state cannot reimburse commercial health plans in that same manner. If it tried to do that, it would violate federal rules.
That's one of the problems here. So let's talk about some of the differences. What about the revenues generated under each? Do they differ? Does it differ in who pays and how much they pay?
Yeah, so again, assuming that they're both designed to raise the same amount of total funding, let's say $1.36 billion for the state.
Let's just say.
Yeah, that just happens to be what the governor proposed in January.
Right.
Under a tiered tax, for example, the whole liability on the whole health plan industry would be about $670 million. And of that, the three largest health plans in the state would be paying less than half of that total liability.
Okay.
But under a flat tax, the total liability would go up to $950 million, excuse me. On
that's
the
like
whole
a 50% hit. That's a big jump.
That's a very big jump. And also the largest health plans would pay a lot more, but some mid-sized plans that don't do a lot of Medi-Cal would pay less.
Well, there you go. Who's ever paying less is going to like one plan over the other for sure. So what about revenue stability and predictability under each proposal?
So it seems like the flat tax is more stable and predictable, and the main reason is because under a tiered tax, the tiers are based off of enrollment size. So if you've got a lot of market changes where plans are merging with each other, and we know some of those mergers are taking place right now, you could get into a situation where the revenue comes in a lot lower than you expected. Whereas under a flat tax, you've got one rate by definition, and that wouldn't change depending on how big or small each plan is.
So it sounds like the tier tax situation, I don't want to say it's an administrative nightmare, but it's certainly much more difficult to administer than the flat tax.
We think so, and the reason is because not only would you have these revenue changes, but also if the enrollment changes are big enough within a given year, you could get into a situation where the tiers are no longer federally permissible, and the state would have to go back and revise the tax tiers and resubmit them for federal approval. You wouldn't have that problem.
Got to go through the entire approval process?
Potentially, yeah, if you got to the point where the changes were big enough for that to happen.
And that's possible?
It's possible, yes.
Okay, so given the way federal reimbursements work, which one of these approaches, the tiered tax approach or the flat tax approach, is going to generate more as a federal reimbursement?
In general, the tiered tax is going to draw down more federal funds to get to the same total state funding
So
goal.
let me get this right. So the tiered tax is going to draw down more federal funds. It's going to be cheaper overall for the industry by 50%. I mean, 600 billion versus 600 million versus 900 million.
Almost a billion, yes.
Yeah, almost a billion. And then it's also less expensive for the largest companies.
That's right.
Okay, I'm just thinking, there's a lot of numbers flying around here.
There are.
But the reimbursements that they're going to get from the federal government, it works better in the tiered tax situation.
Yes, and that's because of the way the tiers are designed. Now, what that means potentially is that if you believe that health plans, like other businesses, pass along the cost increases from a tax onto consumers,
which is a fair assumption.
Yeah, I mean, let's go with that for now. If you believe that, then potentially under a flat tax, consumers and employers who buy health insurance in the commercial market, including the state through CalPERS, could end up seeing higher premium hikes than under a tiered tax.
So I think some people think, well, flat tax, that seems pretty simple and pretty obvious and seems pretty fair. But what we don't realize is it's actually going to cost more for consumers, more for companies, more for the companies that are dealing with Medicare. So you got to look maybe a little more closely.
There are trade-offs.
Yes. And you are giving us that information. So what does all this mean for the state budget? Can you sum up quickly what this means for the state budget?
Sure. Well, again, the reason why I started off with my assumption that they both get to the same funding goal is that if you design it that way, for the purposes of getting that 1.1 billion for the state budget plus the other 200 million for other purposes, both designs could get you there. But they would have different downstream effects and other indirect effects in terms of the impact on the commercial market, which could feed back to state health benefits for workers.
So I want to thank you for explaining the difference between a tiered tax and a flat tax in a way that people can actually understand. So thank you for that. Up next,
you're welcome.
Some of the key capital players in the healthcare debates weigh in. That conversation in a moment. This is the Maddy Report. What are the thoughts of the Capitol's key health policy experts on Medi-Cal and other healthcare issues? Our guests are Anthony Wright, the Executive Director of Health Access California, a statewide coalition of healthcare consumers, and Bill Emerson, the Senior Vice President with the California Hospital Association. Welcome.
Thank you.
Bill, let me start with you first. We've been discussing this new MCO tax, whether it should be a tiered tax or a flat tax. Is that something that's really important?
Yes. It's health care issues are complex to begin with, and the MCO tax is a very complex issue, and it should be a tiered type of tax so that it's
So
more
you would agree
fair
with the
to
governor on that?
I do, absolutely.
Yeah. What do you think about this whole issue of this tiered tax versus flat tax?
The key thing for consumers is that we don't have $1 billion in cuts into our Medi-Cal system. That would be debilitating for the healthcare system that we all rely on, not just the 12 million people with Medi-Cal coverage, but we all go to the same hospitals, the same healthcare system, and this is an important way that we draw down federal funds into our healthcare system, and we can't lose this. The MCO tax has existed for many years, but we need to revamp it, and we need the political will to be able to pass it in whatever form is the most able to pass muster through the complications of the legislature and the insurers and the other players at the table.
Literally the $1 billion question. That's why it's important.
That's
it's
exactly
$1 billion.
right.
So let me ask you this, Anthony. In terms of the MCO tax, this $1 billion is at stake. It seems, though, that the governor forgot a basic maxim of politics, and that is nothing gets done until it has to, because this is not going to really happen until next year.
But we are starting the planning process for what the budget looks like next year, and so it actually, we are running out of time. The January is when the governor presents the budget for the 2015-2016 budget year, and so basically because of the inaction in the special session, the governor is going to have to present a budget that considers the loss of about $1 billion, and so is going to have to potentially propose cuts of that magnitude, which is a huge amount. I mean, it's hard to imagine how much $1 billion is. It sounds like an Austin Powers number, but it's actually, but it's really big. It's a magnitude bigger. The provider rate cuts that we've had, that we are still trying to restore, those, if we did that, that's 200 to 300 million. So this is 3 times more. The fact that we lost dental and 10 other benefits in the Medi-Cal benefit package in 2009, we're still trying to restore. Restoring that would be about 100 million. This is 10 times more. So this is giving you this is a really big deal to make sure that we fund the healthcare system that we all rely on.
So it's $1 billion hole is a big hole. My understanding is the state pays about $18 billion toward Medi-Cal.
That's correct.
So $1 billion of that is a huge hole.
It's a huge hole, and it's a major problem to healthcare. And it needs to be resolved before, as Anthony mentioned, before the budget negotiations. Otherwise, I think we're looking at cuts.
Yeah, so you have this kind of extending the special session now. Hopefully we'll get it resolved. But if it not, it kind of bleeds over into the budget negotiations of next year, and then maybe a proposition in November. Is that a possibility? I don't know. But before we get there, let me ask you this, though. There's some other looming healthcare issues. Covering the remaining uninsured, Medi-Cal reimbursements, more services for the developmentally disabled, in-home supportive services for the elderly and the disabled so they can stay in their homes. Do you think it's going to be addressed in the next legislative session, all these big issues? Or is this thing something that's going to kind of drift over into the November ballot?
You ask me, will it be or should it be?
Okay.
And it should be. All those issues need to be addressed in the next budget cycle.
What do you think, Anthony? Do you think these things are going to get addressed?
Well, I think that there has to be some resolution on this MCO tax, because I think everybody recognizes that we just can't have this hole in our budget. I think, frankly, we also need to take some additional steps. That's why the special session was also considering not just continuing this existing tax on managed care plans, but also a tobacco tax, something that we haven't updated in years and years and years. We're actually 48th in the nation in terms of since the last time we updated our tobacco tax, and a $2 increase in the tobacco tax would raise some money that we could go to restoring rates in Medi-Cal and improving access in the program to some of these other priorities that you outlined. So doing the MCO tax just keeps us at the status quo, which was already underfunded. We need to have some more investment in the system, and that's why a tobacco tax is interesting. You're right, though, if something does not happen in the legislature, the tobacco tax may be something that we have on the ballot. That's something that we're advocating very strongly for.
I don't want to put you on the spot here, Bill, but we've got 30 seconds left. I'm curious as to your organizations, have they taken a position on a tobacco tax?
We are in the coalition on the tobacco tax, and we're also in a coalition to look at extensions of Prop 30 taxes.
Okay, so then that would be focusing primarily on wealthier Californians? Prop 30 basically did.
Yes, it's extending. There's going to be some negotiations on that.
So if you're not a smoker and you're not wealthy, this may be a tax you'd like. So anyway, I want to thank our guests, Bill Emerson with the California Hospital Association, Anthony Wright with Health Access, Felix Su from the Nonpartisan Legislative Analyst's Office, and Jennifer Kent with the California Department of Health Services. Thank all of them for joining us. If you want to stay current with state and local politics, you can look on our website at maddyinstitute.org or check us out on Facebook or Twitter. This is Mark Kepler for the Maddy Report. Thanks for joining us.
The views expressed in the Maddy Report are those of the individuals participating in the program and do not necessarily reflect those of the California Channel or the Maddy Institute. If you'd like to share your thoughts about the points and opinions expressed on the Maddy Report, visit our website at maddyinstitute.org.